The use of information on this podcast or materials linked from this podcast is at the user's own risk. The content of this podcast is not intended to be a substitute for professional medical advice, diagnosis, or treatment. The opinions and ideas expressed are those of the hosts and guests and do not necessarily represent the views and opinions of any organizations we may be affiliated with. As always, follow your local protocols. And welcome back, everybody. I'm Phil Aguet, joining you from Chicago with a special intro episode for one of the newest members of the Triple M team. Joining me this evening, the one and only, well, I don't know if you're a junior or not, actually, Jason Kells.
I am not a junior.
Paramedic and SWAT medic and now med student and a whole bunch of stuff. I feel like we're kindred spirits. I'm going to like this. We're going to do an interview episode where we're basically going to just ask him a bunch of questions and see where it goes. We did one for Dr. Collins, and I think we still need to do one for Reagan. By the way, Dr. Collins is here, if anybody cares.
Hey, guys.
This is more of the casual episode. We're not doing a protocol. We don't have a lot of science stuff to give you. We're letting you know kind of who we are piece by piece. Eventually, they're going to crack the code that is interviewing me. I don't want to do it. I just want to be in the background, just side stage. I'm just fine with it. But I think
what a glorious episode it's going to be when we make that happen.
They're going to make me do it. So to just sort of introduce everybody to one of the newest members of the team, Jason Kells. Who are you and where are you and what's your deal?
Yeah, my name is Jason Kells, obviously. I'm coming to you guys from Grand Forks, North Dakota. I'm a first-year medical student up here. They went into my background a little bit. I did 5 years as a paramedic in the cities, and then on top of that, did some specialty team work while I was down there. I did SWAT for a year with one of the larger counties, and then I did some time with a NICU team down in the cities as well. That kind of had a regional spread. So I got to see a lot of really cool medicine side of things before I moved over to the actual med school education.
Yeah. So paramedic punishment training wasn't enough. You decided, I'd like to be a professional science book reader.
Yeah, I kind of got caught by that EMS bug when I was young. I did my EMT when I was in high school. And then from there, it was just one thing after the next where I'd have these calls where I was like, man, I wish I just knew that little bit more. Yeah. First one was a femur fracture in a kid, and then moved on to a couple of hard resuscitations. If I had known what a case study was back then, I would have had some really good ones written. Of course, I didn't. So, and that, yeah, just kept bringing me that next step until here I am. So
I love this new thing where we're getting a lot of EMTs and paramedics that are becoming docs. The more, the better. I think it translates so well to be able to talk to somebody and know that they were there. They've been there in all of the ways that there is for EMS, because I feel like when you say EMS to people, they picture an ambulance and they picture the uniforms, they might picture the fire departments, but I don't think that we can really articulate what it's like to see the things that we see, and not to sort of belabor the dramatic parts of it, but to exist amongst EMS people. And we are kind of special. Are you from the rural areas?
So kind of a weird story for me because I've moved around a number of times. Majority of my life actually lived in the Twin Cities, just north in one of the suburbs. So grew up with the suburban side of things. Was part
That's Minnesota for everybody who doesn't know. People from Minnesota, they're very nice. They think we know what that means. You don't say LA or Chicago or New York, man. All right, the cities, the Twin Cities. Yes, Minnesota. Yes, huge place, I heard. Go ahead.
Well, suppose it's not much different from saying you're from Chicago and you're from Naperville, though, right?
That's correct. That's correct. That's right. That's what they do.
Yeah, so I grew up in the cities, the Minnesota. And as Phil mentioned, we're kind of nerdy people. And so I was part of a high school pre-health club called HOSA back in the day. And I was doing a leadership thing out in Washington, D.C. with that. And I met a recruiting officer for a fire department for Alaska who said, if you want to get your paramedic, it's the place to go. And I said, no way am I going to Alaska. And then next thing you know, I was in Alaska doing my undergrad.
Of course. Fantastic. Good moves right off the bat. That was right out of high school?
Right out of high school, I moved up to Fairbanks, Alaska.
What'd your family say? You're like, "I'm moving to Alaska to become a paramedic, and I'm gonna be on this Alaska Fire Department."
I think they were happy I got into college, to be honest.
Hey,
Uh,
alright.
so I had some other focuses in high school besides my academics, and
Sure.
kind of bit me. But got into Alaska and I moved up there. Got onto a small fire department just south of the town, and from there just fell in love with Alaska. But the darkness gets a little much in the winters up there, and that aspect wasn't for me. But yeah, I was up there for all of paramedic school, but there's not actually enough ambulances in the state of Alaska to do all your ride time. So they ship you out over the country, and I came back and I did mine in Minneapolis, St. Paul area. During which time I kind of got to experience what urban medicine was like, which was a very different experience from the taiga of Alaska. So
Yeah, that's wow, that's wild. So, you're in Alaska, you're doing the firefighter stuff, you're doing the paramedic stuff out there. By the way, if anybody, like, really wants an adventure, and this is on my bucket list, Alaska, not only do they need the help, they pay for it pretty well, I heard, and they, really appreciate it. So they like having medical professionals of a bunch of different levels around because it can be kinda tough, right? The rural like, the villages and stuff, like, it can be pretty hard to get to somebody who actually knows kinda more a little bit more than the basics, right?
yeah, talk about healthcare disparities and stuff. That was a really eye-opening experience for me. During my time at medic school up there, I got to do some fly-alongs with one of the services. So we got to fly into some of the villages and see the care that was provided, and it ends up being a lot of PAs and NPs that are taking care of full towns. They're the highest level provider in the town, and they do a phenomenal job from what I've seen. And just that interaction of taking care of a critical patient in one room that's intubated on a ventilator, and then behind the curtain in that same room, there's someone with an ear infection, and they're co-treating both of them. As someone who was 18, 19 at the time, it was an eye-opening experience to see the differences between that and some of the big hospitals in Minneapolis.
I mean, how soon was it that you're like, "I think I'd like to throw on a white coat one day?"
I started thinking about it young, like when I was in medic school, but it was one of those inkling things where it's like, well, maybe at one point in my life I might consider doing this. I really fell in love with especially like cardiophysiology and the electrophysiology aspects of that. And so I got really good at that in medic school to the point where I was frustrating my professors because I was attempting to correct them on things despite not knowing anything at the time. And I was like, at some point, maybe I'll pursue this further. Got to the streets, started practicing on the streets, and started having some calls where it's like, I wish I had a couple extra things I could do. And that brought me to critical care. And critical care was great. It gave me that extra bit of training up until the point where I had that first call or that first patient on the streets that I was like, this patient needs hypertonic saline or mannitol, and I don't have it. And I can't give it because I'm not a critical care medic right now. I don't have a critical care truck. So it was one of those things where it's like, I know what it's needed. I just can't do it because of where I'm at right now. And so it was the next step to be like, I've seen what education can do for knowing what treatments can do. I want to pursue this further. And it brought me to the next step of, well, I guess it's time to go back to college and pursue for me, it was a post back so I could apply for med school.
I mean, you're speaking my language because the same thing happened to me, not for med school, but for nursing school, and then now for my DNP program, but I want to know more.
I think it's like being given a box of puzzle pieces and trying to put them together. And every step of education you get a little bit more of a picture from the top of the box at what you're trying to build, and you're not just blindly putting pieces together as much. At least that's what I envisioned it as initially too.
How'd you like the rural patients?
So moving up to Grand Forks, I got onto a couple of departments up here, and I thought had some rural places that I worked back in the cities. Had an opportunity to work in both urban and more rural environments, but moving up here, I really got to get that full experience, something more so than, well, I have a level one trauma center 45 minutes away. And that was an experience to be like, best place for this person I know is an hour away. They don't warrant quite a helicopter at this point. Do we bring him to the nearest place for stabilization, knowing that we're going to be bringing him down here in an hour, or do we just run him down now? And then on top of that, the limited resources that are available. That we talked about it a little bit on the first episode of the Kleinschmidt podcast series. I talked about that a little bit with whether or not you could pass your pager off to someone, and that was talked about with when one of these hard calls drops. Are we able to pass off our pager? In the cities where I was used to working, I had 11 trucks on. If I had a bad call, I had the opportunity for someone else to come and jump on for me. Up here, I've seen that there's not that same opportunity. You rely more on the community aspect of your peers coming in and taking that for you, and it's been really cool to see. It's really rewarding and kind of telling my wife, pushing me towards working in more of a rural environment in future because of that community aspect.
I've been so spoiled having I mean, I could throw a rock and hit 5 trauma centers, and there's a host of community facilities in between there that I could go to. I mean, it's never ending. I don't know. I think 8 of my neighbors are surgeons. Like, it's a lot of people around here. I spent 10 days in South Dakota recently, the Pine Ridge Reservation, and I spent some time at their hospital, Pine Ridge Hospital, which was super cool. Like, they had, like, 2 floors, I guess, if you call it, like, the lower floor and then the ground floor, but everything was there. Everything you would expect in a hospital was there. It was just smaller. And it wasn't maybe open all the time. It was open a couple days a week. And then this one was open a couple days a week, but it was all kind of there. It was all spread out, kind of ranch style. And I was amazed at what walked through the door. And then I talked to the medics that were in the area and I heard some stuff that I don't even think I could have imagined. I mean, they were talking about the availability of extrication tools and that there was like one emergency manager in the area that had some extrication tools that could be used in certain cases, but that if they were on the wrong side of the reservation, the fire department in Nebraska, that was kind of out of their catchment area. And so, consequently, and talking about social determinants of health and health disparity, that's like well known knowledge on the reservation. And so, some people decide not to wear seatbelts because they don't want to be trapped in a vehicle with really kind of extended times or maybe no chance of getting out, particularly if it's on fire. And the medics are like telling me this, and I think my jaw was like mopping the floor. I'm like, what? They're like, yeah, they won't wear seatbelts in the hopes that they'll be thrown from an accident. And there are plenty on the reservation. And that will hopefully give them a better chance of survival instead of being trapped in a vehicle that gets into a body of water or lights on fire or does anything like that when help is far away. Like, this isn't anything I've ever even thought about. Like, what? I thought you dial 911 from anywhere in the country and it's there. Anything you need, it's on the way.
On that note too, when I first moved up to the service I'm on now, I was talking with my boss during the interview I had about the services that we had and the staff that we had on, and I asked how many medics there was at our department, and I was told that I was gonna be the 3rd medic in the county, not just at the department, in the county. Sometimes back in Minneapolis, St. Paul area, I wasn't even the 3rd medic on the truck, and so going from one environment with comparatively of abundance of medics to the county I'm at now where I'm the 3rd one and they're working on a couple more is it was a huge change.
Now let's get into a little bit on the job stuff. And you joined us for the first episode in our Kleinschmidt series. But for folks that are listening from all over the place that have they have their types of calls. You bring to the table this rural, urban, and then a law enforcement sort of angled application of medicine. What was the SWAT experience like, and how did that differ from what you did, kind of in the other two settings?
That was one of the coolest things I think I've ever done, and I was beyond fortunate to get that opportunity to be on that team. I had done a training MCI scenario for active shooters for schools in our service area, and afterwards I went home and I told my wife if I ever got the option to go to the SWAT side, the SWAT medic side, I was going to try out at the very least. I wouldn't let myself be the reason I got told no. So I said that and then kind of figured since those spots are so hard to find that it wasn't ever going to happen. And 2, 3 weeks later, that posting came up. And I said, all right, well, I said I would do it if it came up. And so I sent my application figuring that I wasn't going to get pulled for it. And I got pulled to at least try out, did the tryout, and then had to tell our command staff that I was in the midst of medical school applications, and if I got in, I was gonna have to leave the team in 11 months, and if I didn't, they'd have me for at least a year, and I was fortunate enough or unfortunate enough, depending on which side you're on, to get in on the first time. So I got about a year's time in on that team before I had to unfortunately tender my resignation.
Yeah, that's one of those things I think when you have lots of opportunities coming in front of you, you're like, I really actually do have to make a choice. You're coming into medical school now. You have lots of classmates with varying backgrounds. Do you feel that it gives you an angle that they appreciate, or does it kind of isolate you, being that you have kind of a solid background as a, for all intents and purposes, like a provider already, you know?
I think it does, of that and a number of things more. It's given me a perspective I'm very fortunate to have. I have that experience building differential diagnosis. I have some of these background in some of the meds that we're giving, or at least the classes of meds, especially the ones that you see on patients all the time. That being said, though, coming in as a second career, well, a lot of my classmates some of them have just graduated from college. It's almost isolating in the fact that we've lived such very different lives that it can be difficult to relate, especially when it comes to talking about stories about things that we've done, things that we've seen. And I have to remind myself that despite being in medical school, not everyone wants to be an emergency room person and doesn't want to hear some of those stories. And to me, those were normal. So it's building that filter. It's also building that understanding that despite having this background, for the view of myself, I have to see myself to some degree as a first year medical student. There's a line that I have to hold that I can't step out of and be like, well, I would do it like this because there's a level of professionalism that I have to hold where I'm not that full provider anymore and I have to work as a student, which is also good for me to do because it forces me to actually think before speaking all the time. And then the other aspect of this too is I have EMTs in my class and that I've formed good relationships with, but it's not always the same experience coming from working as a medic in one of the cities to working on a volunteer service as an EMT. Though we have a lot of the similar experiences, they're still different nonetheless. There's a lot of different aspects that it brings, both beneficial and some that provide me with some challenges for sure.
You're seeing healthcare kind of from a bunch of different sides, and I'm wondering what you think will be your impact or what you hope your impact is now that you're moving into the doctor side of things. What are the things that encourage you? What are the things that concern you?
I think in all aspects, you could ask about anything and there'd be positives and negatives, especially if you look at any healthcare system across the world. You'd see some positives and you see some negatives. We have some advantages here in the US where we have our specialty care is phenomenal. If you go to our specialty centers, there is care being provided that a lot of the rest of the world doesn't have at a caliber that the rest of the world doesn't have. That being said, there is an access issue to get to that care. I was fortunate enough to grow up with extremely good health insurance in a city where I had access to every piece of healthcare I could ever imagine. Turning 26 this year, and as such, I'm losing my insurance, and I'm starting to look at that for the first time and actually see what things are going to be like without having that tier of health insurance. Fortunately, I'm in a position where I'll be able to get other health insurance, but it still is going to be limiting compared to what I had. In saying that too, looking at the health system that we have up here in Grand Forks, talking before about even as you mentioned in Chicago, you can pretty much trip over every trauma center. We have one major health system up here with a few other clinics and specialty systems, and it's a lot harder to get appointments. It's a lot harder to be seen in any level of care, whether it's primary care, all the way up to waiting months to see a specialist. And I think that's one of the issues that a lot of the rural communities are facing is that A, to get that access, you have to wait months, but B, at that point, you're driving such a distance to be seen that there's a block in that ability to get that care. Where we're going to solve that, I wish I had an answer for you because I feel like I could probably make some pretty decent money off of it at least. I am hopeful that, especially post COVID, with the use of video conferencing, video healthcare, we're going to continue to have benefit from that. I know that there are some pushes to get providers from other states to be able to use their license from the other state to be able to provide primary healthcare in more rural areas. Also, with the increase in the NPPA level provider, too, taking up some of that, I'm hoping that more individuals will be able to get the care with the increase in providers.
You are learning a lot of stuff that we just don't ever get to learn because we don't have the time to learn as paramedics. And I'm wondering how you view some of the things that you're studying now in relation to what you knew as a medic and or what you know as a medic.
There were items that when I was working as a medic, I thought I was really strong on, and I had a really good understanding of how they worked. And I have since then been educated that I had a vague understanding of how it worked, and it went a lot deeper than that in a lot of different ways. Speaking like specifically, right now I'm in the midst of my neurology unit. I thought I had a good understanding of how strokes worked and stroke assessment and all those. And sitting down and learning, for instance, in this case, the different arteries of the brain, which sections they feed. And as such, if you have a stroke occur, an embolus travel to, or a thrombus form, the presentation that you get. It was something that at the time I was like, oh, well, it's the fast assessment. There's a little bit more that goes along with it, obviously. I never really put together the fact that there's such depth to the information that you can go to. And it goes even, I'm sure, even deeper than my understanding currently of it. It's actually been probably one of the most rewarding factors about medical school is, as we learned as medics, knowing a little bit about everything to filling in some of those gaps, or in other cases, digging out a hole even further so I can fill it in more from my misunderstanding.
Yeah, I think I was explaining to somebody, the if you visualize paramedic and nursing education side by side, my line of education was a lot longer, but it was pretty shallow. It's only like, a couple inches deep below the surface. And my nursing education, I really felt like the line wasn't as long because, we're not doing certain things as nurses. There's like a nurse arena, and that's the stuff that we're really focused on. But I am miles deep as compared to what I learned in medic school about disease processes and presentations and downstream effects of one thing or another of medications. And it has really, really been an experience. I wonder, some of our listeners are mostly EMS folks and paramedics, EMTs, first responders. I wonder if you could envision yourself as a project medical director, as a medical director of a service one day. What are some of the things that you think you would like to remember and then potentially have an effect on that you experienced as a paramedic?
I think looking back on my experience as a medic, I want to take the time to really know my medics and understand the positions and backgrounds that they're coming from, and what really drives them to work. I've had the fortune to work with some amazing medical directors who did take that time and provided me with the opportunity to learn and grow as a person, and really saw in me the want, the drive to do more. I'd really like that opportunity, I think, in future to give it back to another medic.
Yeah, we often talk about accessibility. Dr. Collins, one of the things you say quite often, and I love, is that you always want to be a resource that people can come up to and feel like they can come up to and ask questions. We talked about resources one day, and I was thinking about all my books and all my podcasts and stuff. And he was like, yeah, principally, I hope your medical director is your resource. And I thought about that for a second, and I'm like, man, wouldn't that be nice? Like, wouldn't that be cool? And I've worked for at least a couple really good medical directors. I've a great one now. She's really engaged and just now kind of taken over the seat, but in my dealings with her, just fantastic and really based in education, which I love. But there have been ones in the area anyway that I could tell approaching them would be a chore. I don't ever want anybody to come up to me and ask a question and then feel bad for asking a question. We talked about that a little bit in our education podcast. We teach because we want you to learn. I don't teach because I want you to think that I'm the smartest person in the planet. And I don't like people who teach with that underlying tone. They want you to know all of the things that they know, not because they want you to learn it, but because they want you to know that they know what they do. I'm like, come on. It comes off so obvious when someone is teaching you something so that they can hear the sound of their own voice. And that I think as medics, as EMTs, as first responders, you're oftentimes behind a couple different walls. One, my license only goes so far. You're a nurse, you're a doctor. And two, there were definitely points in time when my education level only went so far. And I stopped myself from saying things because I didn't want to sound stupid. I didn't want to feel I was less than or have someone question my ability as an EMT or a paramedic because I said something that was inaccurate or not the way that they say it and not the way that they learned it. So I was afraid, and that stopped a lot of conversations. That stopped a lot of questions.
I was fortunate enough this last weekend to actually attend a session that was set up by one of the regional trauma centers simulation team. And the approach that they took on it was actually extremely interesting for me. They made everyone sign a confidentiality contract right off the bat. And at first I was kind of confused on why there was this for a fairly basic procedural sim. Why we had to sign a confidentiality contract. And then when he explained it to me, it made sense. And it goes exactly off of what you were just talking about. Yes, there was confidentiality in the aspect of the actual simulation, so you couldn't tell other groups what was going on. So they had an advantage. But it was also so that you couldn't turn around and, as they say, gossip to your colleagues about how other people are doing, what other people are thinking, the questions that were asked. It gave everyone that veil of secrecy to be able to ask the questions that they've been curious about. Specifically, the session that I was at was actually, I was co-teaching. I've been part of an education team for that high school EMT program that I initially had went through for going on probably 6, 7 years now. And to have that opportunity for them to ask that question, those questions were huge without that fear of their classmates talking about it, especially with a high school group. I think it doesn't change as you age, but high school is specifically a time of concern for most people, and it provided them that opportunity.
Just switch gears a little bit. You're in your first year of medical school. You got 3 more years to go. You have residency in front of that, which I think for you will be 4 years.
Probably.
And so you're looking ahead. Do you have any predictions for where you're going to end up? Do you have any predictions for some of the things that you think you might want to do? Where do you see yourself? It's kind of hard. I know, you're at the kind of the bottom looking up at the hill, but where do you actually really kind of want to do? What do you want to do with this? What you're attempting right now?
I have this talk with my wife quite often because it's almost as if everything that I find cool and shiny at right at this time is what I think I want to do. So the prospect for the first time in my life, I've had the prospect of potentially even going into surgery, which is something that I never thought was going to be an opportunity for me. I always look back and I always have such a fun time when I work on the streets, on the ambulances. And part of me wants to come back and do that side. And then part of me during my pre-med time, I had the opportunity to shadow a pediatrician, and I didn't know what to expect walking into that, knowing only the emergency medicine, the NICU side, that aspect of things. Walking into a general practice pediatrics clinic, I love that time with them. It was one of those things, and I talk about it in the Kleinschmidt series, but I have a very checkered history with bad kid calls. And for the longest time, they made me really nervous to be around, just on the basis that just a gut reaction from the calls I've been on. And to be in this clinic where it's, yeah, some of the kids were sick, but overall, comparatively, they were pretty healthy. And look at growth charts. And that aspect I found super interesting as well. It was almost joyful in comparison to, yes, EMS is fun in some aspects, sad in others. You meet a lot of really good people, but there's a layer of joy that I think is missing that I saw in pediatrics, which was kind of something I'm keeping in the back of my mind, but I don't know if I'll fully pursue.
What an interesting sort of experience. You describe it as almost being cathartic. Like it was good for your soul to just see some joy and some good things.
When I got into medical school, I wrote a letter to that doc that I was shadowing, and I said pretty much that exact same thing. I think it was something I needed really badly.
We talked about a whole bunch of stuff in this interview, just trying to get people to know you, that the listeners are going to hear your voice ever so often. I love when they have like a good foundation and they can relate to you for whatever reason they sort of pick out. But I wonder if you had anything that you wanted to say to the folks on the front lines, kind of doing it every day. If you had a message for them, or if you had any pearls of wisdom for the folks that are just starting, or even the folks that are middle and end of their careers.
I will pass along something that I've been doing that I've found cool over the years. Everyone says talk to your patients. And there's a layer of that, especially in emergency medicine on the EMS side, where yes, we talk to them in the sense that we take a history, find out what hospital to bring them to, that nine, or that sort of communication. I started when I was fresh out of medic school talking with especially my elderly patients and asking them a very similar question. And that was, at the time when I started doing this, I was 20, and most of these patients I was talking to were well into their 80s. What advice would you give to a kid like me? We have such an opportunity in medicine to interact with people from every background and from every population, every age, that when appropriate has a chance and usually wants to say what they've learned. It's been really interesting watching people light up at that. The one I remember best, she was this 85-year-old woman, and I asked her, and she lit up. She went from chest pain, sad, anxious about what was going to happen, to an absolute firecracker. Was excited to tell me what she thought that she's learned through her life and provide me with that background to hopefully know that I could use it going forward.
My mom's been a nurse for my entire life, and her interactions she kind of specialized in like geriatric wound care. So we had a lot of like home health visits that I would go on with her. And they were always like older patients living in their home, maybe with a caregiver. And she would be there for like a series of weeks to just walk them through a problem post surgery or a wound or something. And I always loved how she talked to her older patients because she was among the few people that didn't talk to them like they were children. They're older adults. They're not children, and they have things to say and they have thoughts about what's going on. And they may not know every piece of technology that's happening right now, but like they have plenty to tell you if you listen. And one of the things that she always did, and one of the things I used to kind of think was kind of corny, and they do teach it to you a lot in nursing school, was this idea of like therapeutic touch. And I remember hearing about it and rolling my eyes. I'm like, oh God, sure. But I've worked it into like the way I interact with people, particularly when people are having so many struggles with mental health and substance abuse and just life and being sick and being old sometimes and just sort of not feeling very seen. The amount of people who've responded to a literal hand on their shoulder is astounding. There must be some incalculable gap in human touch that we are missing that is right underneath us. Because, man, I tell you, I'm barely trying. Listen, I'm going to help you tonight. This part of it at least will be okay. And you just see tears streaming down people's faces. The pressure and the experience that people are under must be just amazing. And you mentioned this earlier, this ability in EMS and in medicine in general to see people at these different points of their lives. I say it all the time. We see things, we see the human experience from an angle that the majority of people will never even come close to. Never, ever, ever will they see some of the things that we see. And I'm not just meaning like the bad calls or anything. I mean, that happens to all of us. But to be there when someone has realizations, to be there when people like when you see that appreciation for life like re-spark, when hope comes back into their eyes because of something you were either a part of or did or told them, it's wild. And it is really underappreciated. I think in EMS, I think in probably a lot of different aspects of medicine because we're worried about filling out the PCR and we're worried about updating Epic and we're worried about making sure that the paperwork's right so that we don't get in trouble because none of us want to get sued and I don't want to lose my license and all the other we don't want to get QI'd and then be in the hot seat for something. And all of those things drive us just, it might be inches, but it just drives us a little bit further away from just being two human beings experiencing something and one helping out the other. And I really feel that the podcast in general, what we're doing here, I hope reminds our listeners that, like, hey, at the end of the day, you're there to help. And that is a really good thing that if nobody's told you recently, it's appreciated. I don't know who you're helping personally because they're not my family and I'm not in your state. But as a citizen of this country, as a member of the human race, not to get too corny about it, but it's appreciated. There are people that will come into contact with you that will remember you specifically. You won't remember that moment, but they sure will. And it's a really good thing.
I guess one more thing I would want to throw to the question about what else to tell people is when you get the opportunity, we get to a place that you can turn around and give that hand to the next person, to the next group coming up behind you, make sure you do it. As Phil was mentioning earlier in this podcast, we have a huge shortage in this country of healthcare providers in general. And we are also a huge group of individuals in EMS, in nursing, and I guess I will find out about the med school side who like to eat their young, as the saying goes. We have an opportunity to turn around and provide a better upbringing and a better upcoming for the people coming in behind us than anyone else does. We have that opportunity and we should take it. And I will be the first one to say it that I have some probies that I trained on who are absolutely rolling their eyes as I said this because I was an awful FTO for them. I've been told I was a good FTO for some individuals, and I know for a fact I wasn't for others because I got caught into a cycle where I wasn't being the best teacher that I could. When I recognized that, I quit. Quit for a number of reasons, being an FTO, that is. But I recognized that the training that I was providing was doing more harm for the people coming up behind me than good, and I needed that reset. Take the time to train the individuals behind you, give them that good training that you wish you had. But if you recognize that you get to the point where you're not doing that anymore, take a break from it. Recenter why you're doing it, why you love teaching, because there's nothing better than a good teacher, but there's not a lot worse than a bad one either.
Jason Kells is a medical student, paramedic, former SWAT medic, all around cool guy and nerd, just like me and the rest of us here on the Triple M podcast. Jason, thanks so much for sitting down with us and answering some random questions and giving us your insights. And we look forward to hearing from you more.
Thanks for having me.